Let's get started learning the language of the U.S. clinical setting. American clinical culture is characterized by focus on the needs of patients and the preservation of life. Teamwork and efficiency are highly valued. The expression, "time is of the essence," describes the U.S. clinical setting and the language which has evolved. The demand to communicate efficiently has produced a multitude of clinical abbreviations. These abbreviations are said quickly and are exceedingly difficult for newcomers to the clinical area to understand. A second challenge for new healthcare providers is the use of scientific language seen in long, multisyllable terms such as hypothermia or endoscopic. First, let's consider abbreviations. How can you make sense of abbreviations when you hear them for the first time on a clinical unit? It's helpful to recognize the structure of abbreviations. Most clinical abbreviations are used in two forms. They are either shortened words or phrases, or they are first letters of the initials of words or syllables. Sometimes combinations of syllables and letters are used. Let's examine how an abbreviation is formed by shortening. I will use examples that will be presented again in the weekly interactive learning modules. The term vital signs refers to the assessment of body temperature, pulse, respirations, and blood pressure. Doctors and nurses commonly shorten the words vital signs to the abbreviation vitals. They shorten the phrase even more when it is written using lowercase vs. In this course, you will be learning about many other terms which are abbreviated by shortening. The second common form of abbreviation is using letters of a term or syllables in a word. The very common abbreviation BP for blood pressure illustrates the use of the first letters of two separate words, B for blood and P for pressure. Another example is the abbreviation MI for myocardial infarction. A technical name for the use of first letters is initialing. In this course, we use the phrase, "the first letter rule," for this method. Abbreviations using the first letter rule commonly identify diseases and diagnostic tests. For example, chronic obstructive pulmonary disease is COPD, or liver function tests are LFTs. In most cases, these letters are pronounced separately as letters. Some abbreviations do not follow the first letter rule. Sometimes key letters or key syllables form the abbreviation. For example, hypertension is abbreviated using HTN. Or we see the term atrial fibrillation abbreviated as either AF or AFib. Sometimes the first letters form an easily pronounceable word. For example, acquired immune deficiency syndrome becomes AIDS, or severe acute respiratory syndrome becomes SARS. These abbreviations that fit together to form a word are called acronyms. Understanding these principles of structure of abbreviations will help you to more quickly learn the many abbreviations used in U.S. clinical settings. The second challenge for those new to clinical settings is the long, scientifically oriented medical terms used in conversation and for reporting. Each of the syllables or segments of these words are derived from Latin or Greek words and have specific meanings. A long medical word can be decoded by learning the meaning of each of the segments. You will learn more about how to decode long medical terms as you progress through the course. Now we have saved the most important key to understanding a new term or abbreviation until the last. Always ask, what is going on here? What is this situation about? A short way to say this is consider context. For example, if you enter the nurse's station and the conversation is, "We need to admit Mr. Smith," and then the nurse looks at you and says, "Would you get his vitals?" You can be pretty sure that this is a request for assessment of vital signs. Your thoughts might jump to, is she saying something about vitality? Or maybe vital organs? But if you consider the context, it is clear that a newly admitted patient needs evaluation of vital signs. The safety of your patient is always a primary guiding factor. When the use of a term or abbreviation may have consequences for patient welfare, be certain before you proceed. We will suggest ways to clarify what you hear and see later in the course. Let's get started by learning more about terms and abbreviations related to vital signs. In Module 1, you were introduced to many abbreviations related to the assessment of vital signs. You may now feel more confident about identifying clinical expressions that are simply a shortening of a clinical word. For example, temp, used instead of temperature, or pulse ox for pulse oximeter. You have also studied abbreviations constructed from the initials or first letter of words such as BP for blood pressure, HTN for hypertension, and TPR for temperature, pulse, and respirations. You've been introduced to complex terms like hyperthermia and hypothermia. Now we will intensify the process of learning to discover the meaning of these more complex medical terms. You will learn how to infer or think through the meaning of a complex term. Identifying the parts of medical words and figuring out how they fit together is like a puzzle. These word parts are used across the sciences and derive from Greek or Latin words. The parts are usually the beginning or the prefix, the middle or the root, and the ending or the suffix. Often, a word consists of just the prefix and the root, or the root and the suffix. Let's examine the words hypothermia and hyperthermia more closely. Notice that the main part or root of both words is thermia. You have already used this root in the word thermometer. A thermometer is an instrument that measures temperature. So therm has to do with temperature. Then you may recognize the term hyper from common English language usage of words such as hyperactive or hypercritical. Hyper means more or extreme. So hyperthermia refers to high or extreme body temperature. Hypothermia is the opposite of hyperthermia. Can you guess what hypothermia means? Yes, low temperature. The prefixes hyper and hypo radically change the meaning of the root. Here, the prefixes describe the amount or degree of temperature. A prefix or suffix can also indicate size, color, shape, or direction. A key to solving these medical word puzzles is a list of common prefixes, roots, and suffixes. We call this the prefix, root, and suffix list, or the PRS list. The list is available as a study guide in this module and in the Clinical Terminology Dictionary. Take a good look at the PRS list. Notice that the list is alphabetical, that those terms that are usually prefixes are followed by a dash, and those that are more often suffixes are preceded by a dash. Although there is considerable consistency for the role of either prefix, root, or suffix, some terms play interchangeable roles. If you are conscientious and use the PRS list frequently, the Latin and Greek terms simply become part of your new language. Take the time now to confirm the meaning of the prefixes and root for the words for hypertension and hypotension. You will quickly identify the prefixes as the same as in our previous example. Recheck the meaning on the PRS list if you're not sure. Now, identify and look up the root in the PRS list. How do these puzzle pieces fit together? If you had problems with this exercise, you can bring this up on the discussion board. Being an active participant will greatly increase your success in this course. For example, actually using the PRS list for an easy puzzle about hyper and hypotension gives you a pattern for that activity and makes the process more efficient as you work on more difficult problems. Actually practicing saying the terms and abbreviations as they are presented in the course will greatly enhance your learning. Check your pronunciations against those presented in the course audio. Positive experience builds confidence. Soon, this becomes easy and fun. Another way to be an active participant is sharing your learning experience on the discussion board. Keep a list of terms and abbreviations that are difficult for you, surprise you, or cause confusion. Share this on the discussion board. Help others as they share their list. The support of others is very important. You can find fellow students in your city or town and arrange meetups. You can create scripts for mock medical or nursing conversations and then read them to each other. Both the experience of writing the clinical language and hearing it will be beneficial to you. Use the discussion board to suggest abbreviations and terms that you think should be included in the course or dictionary. You are part of a global community of new healthcare providers. We are learning and growing together. Let's go look around a typical U.S. clinical unit. Would you like to take a short tour of a clinical unit in a U.S. hospital? This tour is optional. It is offered to those of you who want to develop a general sense of what a U.S. clinical unit is like. We do not expect that you will grasp every detail or every term used during the tour. When you don't understand something, make a quick note. Chances are that your question will be answered as we cover terms in modules 2 and 3. Also, we are happy to address questions that have to do with the language of the clinical area on the discussion board. The information presented with the video is a supplement to course content. It is an optional learning experience and you will not be tested on any of the information presented. Relax and concentrate on getting a feel for the environment of the U.S. clinical unit. We will start with the nursing station, then the medication room, then a supply room, a kitchen, and lastly, a patient's room. I will point out items of interest and briefly explain what activity occurs in the various rooms. First, we will visit the nursing station. The nursing station is the administrative center for nursing care for a group of patients. Size of the nursing station, the number of staff, and the number of patients served differs widely. Usually, a unit secretary is seated at a central desk. The secretary receives phone calls, answers questions, monitors the transportation of patients, and orders materials for patient care. The nursing station is a communication and collaboration center. Usually there are doctors, various therapists, and other persons involved in the care of patients moving about the station. Nurses often give and receive handoff or end-of-shift report on patients in this area. You will see many computers in use. U.S. healthcare facilities are transitioning to electronic health records. Computers are used in the nursing station and on mobile carts that can be wheeled into the patient's room. Each computer can be used to access patients' records or a data bank of clinical information. Access to the patient's medical information requires password. Notice the casual, loose-fitting clothing the nurses are wearing. These uniforms are called scrubs. Often, the color of the scrub worn varies according to departments within the hospital or the role of the wearer. On this unit, the RN staff wears pale blue scrubs. The head nurse is wearing a white top and blue pants scrub uniform, and the nursing assistants wear green. You will learn more about the roles of these healthcare workers in Module 2. This RN is checking a patient's medical record using the electronic medical record system. This is the medication room. Now the RN is using the medication administration machine. This is a complex electronic system for storing and dispensing medications. Physicians' orders for medications are electronically transmitted to the pharmacy. They are filled there, and then the medication is stocked in the medication room and in the medication administration machine. You see that the RN refers to the computer screen and notes what medications are needed for a particular patient. Then, an electronic system facilitates access to drugs in drawers in the machine. Intravenous solutions are also kept in this room. Intravenous solutions are supplied in plastic containers or bags. The large bags of fluid for body fluid replacement and the administration of electrolytes and medications are seen here. The smaller bags are for administration of medication. The intravenous fluid flows through the bag and through the plastic tubing of the infusion set seen here. A refrigerator is used to store some medications and solutions. Remember, we do not expect that you will be perfectly clear about what you are seeing here. Use of the electronic medication administration system interfaced with the electronic medical record is really quite complex. You are not expected to fully understand it at this time. We just want you to have an idea about what it looks like. You will receive more specific information about it in Modules 2 and 3, and you will get a closer look at what the computer screen is showing. A typical clinical unit will have one or more supply rooms. Here we find a wide array of items for patient care. You see sheets for the beds, light blankets, and gowns for the patients to wear. Equipment for the administration of medications, and these tubes for drawing blood samples from an intravenous setup are stored here. Then there are shelves of patient care items. Most of these are disposable after use. The stack of yellow items are protective gowns that staff wear if there is a possibility of contamination of clothing. These will be more clearly illustrated for you in Module 2. In this supply room, we will find oxygen tanks and equipment to help patients to be mobile, such as crutches and walkers. Let's leave the supply room and look at some equipment found in the hallway area near the nurses' station. This is the emergency cart. Notice its red color. On top of the cart, we find packages containing equipment for assisting with breathing or monitoring and treating serious heart problems. Within its drawers are supplies and equipment to treat cardiac and neurological emergencies. In the drawers, we find equipment to administer medication, and intravenous fluids. Here is the kitchen on this unit. We find a kitchen with easy access to juices, snacks, water, and ice. Now let's take a look at a patient's room. Here you will find a typical electrically controlled adjustable patient care bed. On the wall above the head of the bed, you will usually find an array of equipment. Here we have a monitor, thermometer, equipment for delivering oxygen, suction or negative pressure equipment with a large, clear collection bottle, a blood pressure measurement set, an otoscope and ophthalmoscope with disposable covers for the probes is stored just above them. The otoscope and ophthalmoscope are used to examine the ears and the eyes. This is usually where you will find switches controlling lighting and the system used for verbal communication between the patient and the staff members. In the patient's room, you will find specific bins for disposal of linen and red receptacles for disposal of contaminated items. There is usually a closet for storage of items used for patient hygiene and for change of linen or change of gown. If this room were in use by a patient, it would look very different. You might find many types of equipment. In Module 2, you will learn terms to describe equipment used at the bedside of patients with common surgical and medical problems. Then, in Module 3, you will learn about terms used to describe emergency equipment you saw in this video, and the medication administration equipment and IV infusion equipment that you just got a quick look at here. So after you work through Module 2 and Module 3, you may want to return to this video and see if you can identify items in the video using the terms that you have learned in the interactive modules. We hope that you enjoyed this brief tour of a common U.S. clinical unit. I hope that you enjoyed the tour of the clinical unit. Remember, every clinical unit is different, and how healthcare providers refer to equipment may differ from hospital to hospital. Use the study guide for abbreviation of healthcare providers' titles to help you learn these abbreviations. Keep in mind that how roles and abbreviations used for them are defined varies widely in the U.S. In some places, the nurse who is responsible for healthcare on a particular unit will be called a head nurse, while in another hospital, he or she may be called the unit director or the clinical coordinator. We provide what terms are most common in the U.S. In addition to recognizing abbreviations for healthcare providers' work roles, you will need to recognize abbreviations for locations within or outside of the hospital from which your patients are likely to be transferred from or sent to. Refer to the study guide for abbreviations of hospital-associated locations. In the video of the clinical unit, you saw many healthcare providers using the computer. U.S. hospitals and clinics have undergone a revolution from use of paper patient charts to computerization of most written or record-keeping activities. With strong U.S. government support since 2006, most U.S. hospitals and clinics have adopted the electronic health record. Institutions are required to fully implement the electronic health record by 2015. The electronic medical record system supports computerization of entry of physicians' orders, nursing documentation of medication, treatments, and observations. The system offers reminders, protocols, and clinical decision-making support. Information is easily shared within the hospitals and other institutions. An important part of the EMR is the history and physical examination, usually performed by a physician, nurse practitioner, or physician's assistant. Learning the following abbreviations will help you to read this report and understand conversations about it. You have just completed study of terms and abbreviations used in the delivery of care to the majority of patients. Now we will focus on 3 specific categories of patients: the surgical patient, a patient who is comatose, and an elderly man with respiratory disease. Each patient presents a different challenge for the use of terms and abbreviations associated with his or her care. We will introduce each patient with a short description of the diagnosis and medical history. Use the description and the photos to consider the context in which the terms and abbreviations are used. Try to imagine being in the rooms and part of the healthcare team. Our first patient is Mrs. Gurdo, a 62-year-old woman who underwent colon surgery 2 weeks ago and has developed an infection at the surgical site. You learn from the EMR that Mrs. Gurdo has a past medical history of a stroke or cerebrovascular accident 5 years ago. She has weakness of the left side of her body. She has a tube leading from her nose to her stomach so that she can receive food. She is receiving intravenous fluids and antibiotics. You will be working with a staff RN to care for Mrs. Gurdo. As you examine her EMR and look over the nursing care plan, the charge nurse says, "Be sure to use the PPE that is available just outside the room." PPE? What is PPE? Our second patient is Mr. Taggart, a 34-year-old man who sustained a head injury in a motor vehicle accident, or MVA, 2 years ago. He is comatose, unaware of his surroundings, unable to move about voluntarily, and unable to communicate. He has a tracheostomy and is receiving O2 by tracheostomy mask. You enter the room with the RN. She says, "I will be giving his meds through the PEG tube." PEG tube? What is that? Our third patient is Mr. Cope, an elderly man with cardiac and pulmonary problems. Mr. Cope smoked cigarettes most of his life and now has chronic obstructive lung disease, or COPD. He also has chronic congestive heart failure, or CHF. He requires oxygen supplementation and special stockings for control of swelling of his legs. As you read the EMR in preparation to help care for Mr. Cope, you notice a recent doctor's order. It reads, O2 by nasal cannula at 2 to 4 liters per minute if SpO2 drops below 94%. You wonder, what is a nasal cannula? We hope that you enjoyed your tour of the clinical unit and learning about the terms and abbreviations used to identify the environment, supplies, equipment, methods of recording, and the people you usually find there. You are now ready to learn about abbreviations and terms used in emergency situations and those commonly used when administering medications or intravenous solutions. Before we begin Module 3, we will work on refining your puzzle-solving skills for discovering the meaning of medical words commonly used on the U.S. clinical unit. Let's examine 2 important terms that you saw in Module 1. Dyspnea, defined as difficult breathing, and apnea, the absence of breathing. By examining these words, dyspnea and apnea, we see that PNEA, or NEA, is used in both words. Nia forms the central aspect or the root of the word. Using the PRS list, we find that PNEA means breath or breathing. Then we use the PRS list again and see that dis refers to difficult. Putting together the puzzle, we attach the dis to the PNEA, and we have the word dyspnea, meaning difficult breathing. Using the PRS list again, we find that A often means without. And combined with PNEA, it becomes without breathing or apnea. Notice the dis is used as a prefix in many common English words. For example, the word dysfunction means difficult or impaired function. Recognizing the meaning of spoken and written medical terms becomes quicker and easier as you use the PRS list, memorize the prefixes, roots, and suffixes, and then use them to discover the meaning of a medical word. When you can, try to accompany this with a visual representation. Picture a person having difficulty breathing, or a sleeping person having long pauses in breathing. Take special note of roots. Be clear that the term tension was the root of hypertension, and that the PNEA was the root for dyspnea. Roots are central in the word and central to its meaning. The prefixes and suffixes then describe the root. Okay, let's go on. Module 3 is full of excitement. I would like to ask you to mentally place yourself on a U.S. clinical unit. It's 3 o'clock in the afternoon, and you have learned a lot as you've cared for a surgical patient on Unit 4C. As you leave your patient's room, you hear an announcement on the public address system. Code Blue, Unit 4C. All designated personnel report to 4C. A nurse in the hallway appears intent, just walking right past you toward a nursing station. You're really not sure what's happening. You ask yourself, what's going on here? What should I do? I hope that the first section of this module, focused on abbreviations commonly used during emergencies, has been meaningful to you. In both emergency situations and in everyday healthcare, you will need to understand the abbreviations used when administering medications and intravenous fluids. So let's focus now on the everyday activity of administering medications. There are many abbreviations that define the timing of medications. In Module 4, we work towards mastering common abbreviations for diseases. The names for many diseases contain multiple terms. Consider how long it takes to say chronic obstructive lung disease, or acquired immunodeficiency syndrome, or severe acute respiratory syndrome. These terms are generally shortened by using the first letters of each term. If the term produced by using initials is used as a word, the abbreviation is called an acronym. Two examples are acquired immunodeficiency syndrome, becoming AIDS, or severe acute respiratory syndrome, becoming SARS. The PEG in the term PEG tube you learned about in Module 3 is an acronym. Some abbreviations remain as initials. BP for blood pressure and AED for automated external defibrillator are good examples. Use of initialing is very common. Additional examples that you have learned about are PPE, SCD, and CPR. Technically, these are called initializations. However, most Americans refer to both types of lettered abbreviations as acronyms. In keeping with your goal of learning terminology, not technical English usage, you do not need to differentiate these two types of lettered abbreviations. There are many variations in composition of an acronym. Some retain parts of words, such as sub-Q or AFib, which is an abbreviation for atrial fibrillation. A few use either. For example, you will hear both TED hose and TED hose or stockings. The number of initializations or acronyms used for diseases can seem overwhelming at first. As you memorize the abbreviations, try to visualize the organ that is most affected by the disease. If you have seen patients with this disease, visualize any of the distinctive features of the disease. This will help you to associate the acronym with the name of the disease. Let's work with some common abbreviations for diseases. Abbreviations can be dangerous. The number of acronyms used in clinical conversation is steadily increasing. Some acronyms have two meanings. What is a frequently used term in one hospital may not be used in another. With shortening of a term, some information is always lost, and use can cause confusion and even affect the safety of patients. There are acronyms which use the same letters but have different meanings. For example, we noted in Module 2 that LOC usually refers to level of consciousness, but someone might use it intending to mean loss of consciousness. This abbreviation is used verbally and could make a difference in how you approach or take care of a patient. If you hear this or any abbreviation that you are not clear about, don't hesitate to ask for clarification. Simply say, "Please clarify what you mean by LOC." You have learned that BS, used in the context of medical or nursing assessment, is usually vowel sounds. However, in some settings, BS might mean breath sounds. Since this is a written abbreviation, generally you will be able to look at the context in which it is used and determine if the lungs or the bowels are being described. A similar situation is evident for a frequently misused acronym, DOA, which can mean day of admission or dead on arrival. You are likely to hear DOA in conversation, so you need to consider the context. If someone is saying, "She is really distressed. Her father arrived DOA in the ER this morning," you can infer the meaning. On the other hand, if someone uses DOA while talking about your very much alive patient, then the conversation is about his date of admission. Abbreviations can cause medication errors. For example, the abbreviation HS, generally referring to hour of sleep or bedtime, might be confused with HS, used to indicate half strength. The confusing HS may be part of a physician's order. Don't guess. Seek clarification, or consider how DC might mean discontinue or discharge. Nurses who are interpreting physicians' orders must always seek clarification. The use of abbreviations as part of doctors' orders is so problematic that one national accrediting organization has issued a list of abbreviations that doctors are encouraged not to use. Module 5 focuses on abbreviated common laboratory tests. One way to help remember the source of the acronym is to associate each with the body organ function that it is measuring. A more complete list of common laboratory tests and their normal values is included as a study guide at the end of Module 5. I hope that you now feel more confidence for understanding the acronyms used for indicating common laboratory tests. You have arrived at an important point in your learning process. You have learned how to understand many of the terms that you are likely to hear or see on a general medical surgical unit in a U.S. hospital. Your clinical language skills now include using terms and abbreviations about patient care, as well as diagnosis and laboratory tests. Now it's time to apply those skills to interpret what is going on as you hear and view several clinical simulations. We will start with a very brief depiction of a clinical interaction and then move to more complicated situations. The simulation of the clinical situation will be a video. Each video will have a brief written introduction aimed to help you understand the context in which the interaction occurs. Read the introduction carefully and then start the video. You could view the video as many times as you like. Next, look at the questions that are intended to help you determine if you are understanding the clinical language of the video. If you have difficulty with interpretation of some terms, do not despair. You can return to any part of the course at any time to restudy a term. You can check the dictionary to help recall how a term sounds. And you can share your difficulty with others on the discussion board. Remember, we are a global community learning together.
Here's Mr. Waters. We're so crazy in the ED, we're on reroute. I'm bringing you another patient as soon as you get him settled. I got the admission database done for you, and his orders are written. He's 65, he's allergic to Levaquin, and he fell at home and has an 8-centimeter laceration on his left arm. The Kerlix dressing is dry and intact. He has a history of AFib, hypertension, CAD. His admitting diagnosis is syncopal episode. The vitals for me were 136/84, 98.4, 98 and irregular, 20 and lungs clear, and his SAT is 98 on room air. He's got a 20 gauge saline lock in the right. Everything else is fine. Oh, here are his meds. I took him out, but I didn't have a chance to get to him. But okay. I'll be back in about 15 minutes, okay?
Okay.
Thanks.
Hi, Mr. Waters. I'm Kelly. I'm going to be your nurse. Can you tell me your date of birth?
Why does everybody want to know my birthday? You gonna throw me a party or something? Can't I just get my pills so I can go to bed?
I know you're tired. I'm just going to do a quick assessment, okay? Do some vital signs. And then we can give you your pills. It's Kelly.
The ED called, said they're on the way with your new admit.
My new admit? No, Mr. Waters is already here.
It's the patient for 346B, Mr. Thompson.
I need to talk to my charge nurse because I just got a new admission.
Well, she's in 341 getting the ICU transfer settled, and I got another call. I've got to go.
Are you having any pain, Mr. Waters?
No, I'm not having any pain. My
No?
only pain's from you.
How's this arm?
It's fine. It's fine. No pain. I'm just tired.
Okay.
Can I get my pills?
Let me put this in the computer. It's Kelly.
Lab labels are up for Mr. Waters.
Labs? Weren't they sent to the ED?
I guess not. You want me to bring them to you? No, wait, I got another call. Gotta go.
You done your phone call yet? I'm starved. Can I get a snack? Some crackers or something?
Let me check the computer. You're on a low sodium diet. I'll bring you some juice and crackers.
I want milk, and not skim milk. I always take milk with my pills.
Sorry, we don't have any milk.
No milk? Just give me my pills then.
Okay. I have Lipitor, Norvasc, and Coumadin. You take these at home routinely, right? So you know what they do?
Of course I know what they do. Coumadin thins my blood. Lipitor's for cholesterol, and Norvasc for my pressure, okay? Can we just get on with it?
Okay. Let me scan your bracelet, okay? All right, Mr. Waters, here you go. These are your pills, and here's your water. Hey, it's Kelly.
Your patient's from the ED's here. They need some help to get him into bed in room 345.
Okay, I'll be there soon. Is there anything else I can do for you, Mr. Waters?
No, I just want to go to sleep.
Here's your call button. You want me to turn the lights off for you?
Yeah.
I'll be back in 30 minutes to check on you and do some labs, okay? Mr. Waters, it's Kelly. I'm here to draw some lab work on you that the doctor ordered. Mr. Waters? Mr. Waters?
What? Oh,
Wake up.
you again.
I'm here to draw some lab work on you.
Ah! Oh my God! I'm bleeding. What did people
okay.
do to me?
It's okay, Mr. Waters. I'm
Ah!
here.
It's everywhere.
I'm here.
Ow!
It's okay. I'm here.
Ow! Oh my gosh, my nose? This never happened before.
Okay, it's all right. I'm here. I'm gonna put some pressure on it, okay? Hi, this is Kelly. I need some help in room 346. My patient's hemorrhaging.
Ow!
It's okay.
Hey!
I paced the doc. Mr. Waters, I'm going to help you.
We'll take care.
Hey!
We're gonna take care of it.
I
Ow!
got it. Mr. Waters, I'm here, okay? We're here to help you.
Take some vital signs.
Get me out of here!
Okay, Mr. Waters, we're here to help you, okay?
Gotta stop that bleeding.
That's what we're doing. Putting pressure, okay?
What'd you do? Give me too much medicine? This never happened
Hi,
before.
it's Kelly.
I've got Dr. Youngblood on line 1.
Okay, thanks.
Okay.
Yes, Dr. Youngblood, we have Mr. Waters here at MCGH Hospital with huge amounts of bleeding from his nose and his left arm laceration. The dressing saturated,
Hey!
his pillow
Help!
and his gown is
Hey!
saturated. Blood pressure right now is 90/50, heart rate is 130. He's alert and responsive.
Get me out of here!
Yes,
Ow!
that's him yelling right now. He came from the ED about an hour ago, admitted with syncope. He fell at home and lacerated his left arm. Vital signs 30 minutes ago were 130/78, heart rate of 104, respirations of 18, saturation of 98% on room air. His labs are pending. He's hemorrhaging right now, and I think you need to come and see him right away.
Say, Mr. Waters, he was just in my office this morning for a routine checkup. He seemed fine. I ordered some labs. Let me check those. Oh, yes, an INR of 4.3. Well, that explains it. Give him vitamin K, 10 milligrams, sub-Q stat, and I'll be right over.
Okay, let me read those orders back to you.
I hope that the presentation of the clinical simulation and the in-context use of clinical language in Module 6 was a positive and worthwhile experience for you. You can use this clinical language exposure as a springboard to creating similar learning experiences for yourself. For example, YouTube has many videos with clinical language embedded in them. Watch the videos, stopping and replaying those parts where the language is unclear to you. When you hear an unfamiliar term or abbreviation, consider whether it is a shortening, a first letter abbreviation, perhaps a combination of a syllable and first letter abbreviation, or a medical word puzzle to be solved using that PRS list. Like all languages, clinical language is dynamic. It changes and it evolves. It is a skill that we are all continually learning. Lastly, I would like to extend my appreciation to my co-teacher and designer of the Clinical Dictionary for Beginning International and U.S. students, Michael Gold, and to our teaching fellow, Zan Liang. Also, this project would not have come to fruition without the assistance of the talented staff at the University of Pittsburgh. We all wish you good luck and success in all endeavors.